Thank you, everybody, for joining us today. We are going to be talking about adapting the skin tear classification tool to support Indigenous cultural safety, presented by Dr. Kevin Wu, Bev Smith, and myself, Michelle Buffalo. Disclosures, all of us here have none to disclose. So we're going to start with a land acknowledgement today. We acknowledge that we are gathering today across many homelands, treaty areas, and Indigenous territories. Even in a virtual space, it is important to recognize these lands that hold us and the Indigenous nations who have cared for them since time immemorial. Wherever you are joining from today, we invite you to take a moment to acknowledge the Indigenous nations of those lands and to reflect on how we uphold our responsibilities to relationship, respect, reciprocity, and ethical care in our work together here today. Objectives today: by the end of this session, participants will be able to describe cultural safety and its relevance to skin tear assessment, identify the purpose and basic structure of the skin tear classification tool, and apply the classification tool in practice to support consistent, respectful, and culturally safe care. When we talk about cultural safety in Canada, we are acknowledging that healthcare does not exist outside of history. Colonization, residential schools, and systemic racism are not just historical events. Their impacts continue today and shape how many Indigenous people experience healthcare. For many First Nations, Inuit, and Métis individuals, health systems have been places of harm, control, and loss of autonomy. Recognizing this context is essential when we introduce an assessment tool, including the ISTAP skin tear classification tool. Cultural safety begins with understanding that Indigenous people come to care with diverse histories and lived experiences, and that these experiences influence how safe or unsafe an interaction may feel. Because of these historical and ongoing experiences, trust in healthcare systems cannot be assumed. Some Indigenous people may approach assessments with caution, especially those involving touch, exposure of the body, or documentation. Barriers to access past experiences of discrimination or feeling dismissed or judged can influence whether someone feels comfortable engaging in care, asking questions, or returning for follow-up. When we use the ISTAP Indigenous Skin Tear tool, our goal is not only accurate classification, but also to support trust building by being transparent, respectful, and responsive to the person's comfort level and preferences. Cultural safety places responsibility on us as healthcare providers. It requires ongoing self-reflection about the power we hold in clinical interactions and how our assumptions, language, or actions may affect the person receiving care. This includes reflecting on how healthcare systems have contributed to harm in the past and how those harms may still be felt today. Cultural safety is not about learning facts about Indigenous cultures. It's about how care is experienced by the person. When using the ISTAP Indigenous Skin Tear tool, this means asking permission, explaining what we are doing and why, honoring individual preferences, and recognizing that cultural safety is defined by the person, not the clinician. Skin tear assessment often requires us to touch the person's skin, expose parts of the body, and work in close physical proximity. These are very personal interactions. If cultural safety has not been established, these actions can feel intrusive or unsafe rather than therapeutic. This is especially important to recognize when using standardized tools like the ISTAP skin tear classification tool, which may otherwise feel clinical or task-focused. Establishing cultural safety first helps ensure that assessment is experienced as respectful care, not something being done to the person. For many Indigenous people, healthcare encounters are shaped by past experiences where consent was not sought, explanations were limited, or voices were not heard. When assessments happen without clear communication, permission, or respect, they can unintentionally reinforce feelings of vulnerability or mistrust that are rooted in those experiences. Using the ISTAP Indigenous Skin Tear tool in a culturally safe way means slowing down, explaining what we are doing and why, and ensuring the person has a real choice in how care proceeds. For example, before assessing a skin tear on an elder's lower leg, a nurse needs to pause and say something. For example, I like to take a look at the skin on your leg to understand how best to care for it. Is this okay with you? Would you like someone with you while we do this? This simple pause helps shift the interaction from task-based to relational.
Great, thank you, Michelle. It's a wonderful introduction to the project that we're doing, and I'm trying to explain to you about the methodology that we have used for this project. So, as a group, we have a very clear goal in the next slide. The purpose of the project is really to modify the existing ISTAP tool to ensure the content is inclusive, culturally sensitive, and culturally safe, especially in the assessment and management of skin tears amongst Indigenous people in Canada. So I think this is a very unique project that is the first of its kind in terms of looking at cultural adaptation using an English language tool for English-speaking people, but working in a very different cultural context. And we also involve Indigenous nurses and specialized wound care nurses who work within the Indigenous community as well. So the purpose of the cross-cultural adaptation is to recognize the impact of language on people's identity, on justice, and also on knowledge. And we want to dismantle that power structure. We want to dismantle the existing colonial way of interacting with people by looking and reflecting on language and words that we use. So the original tool do not necessarily produce similar meaningful responses when applied in the Indigenous culture. We want to reclaim Indigenous perspectives and particularly give voice to equity deserving groups. I think, when you look at all the atrocities around the globe, I think this becomes more urgent that we lean into the Canadian values to promote equity and looking at how we can be sure that we're patient-centered. So when we think about linguistic validation, there are actually 4 different concepts. And the next slide, I'm going to show you the 4 different components. So the 4 different components that were mentioned in a few different papers by Beaton and also Crucino, and basically they highlighted the 4 different aspects when we think about cultural relevance and cultural equivalence. So they divide equivalence into semantic, idiomatic, experiential, and conceptual. Semantic, other words, actually, the word itself has the same meaning when you're comparing 2 different cultures. Idiomatic, a lot of times, even in Canadian English, we use a lot of idioms and colloquial terms, and that may not make sense to other cultures. So we want to make sure that we're using the right terminologies. Experiential, do we have elements that describe in pathway that is relevant to people living in the Indigenous area and that relevant to their daily experiences? And the final component is conceptual equivalence. And really, the purpose is to ensure the concept carry the same significance and understanding in both cultures. Give you some examples, like when we talk about, oh, I feel blue. And of course, this is a very colloquial and idiomatic way to express we're depressed and we're not feeling well. And that may not make sense to people when we translate it into the culture. There's also culture that do not have concept of time, or they have never seen snow before. So when we say, well, okay, as white as snow, they really conceptually have a tough time figuring out, okay, what does it look like when I have not seen snow before, right? So even when we think about skin tears, and I think the original ISTAP group can tell you the challenge they face when they're trying to harmonize the language to describe skin tears. In some Latin American culture, they don't have the term skin tears. They use terms like laceration, they use terms like skin breakdown, and so on and so forth. So skin tears is really something that we introduce to their lexicon. And that's why when we're culturally adapting something, we have to be cognizant about some of those differences. So the process, it's a sort of a very linear, multi-stage, iterative process. I'm so privileged to work with this group of very, very passionate people. And every time I'm in the meeting, I'm reminded by the group that, well, we need to talk about justice. We have to talk about to make sure that things are kind of not negative. We want to convey a positive idea when we talk about skin tears. So we included 4 nurses who identify themselves as Indigenous. So we had the nurses work closely in the Indigenous community. We started with a panel survey looking at the tool itself to highlight some of the areas that we need to work more in depth and more closely to evaluate the individual item relevance to the Indigenous population. And then we organize and schedule the few focus group interviews. We use the cognitive debriefing technique to allow the group members to exchange different ideas, talk about some of the areas that is vague, ambiguous, that require certain modification. The group, we do have some specific criteria to ensure that they're all experts in the area. They're all NSWOCs. They worked more than 5 years in the area of skin and wound care practice, and also work closely with the Indigenous people. After the cognitive debriefing, and we highlight some of the key elements, some of the key themes that emerge from the conversations, trauma-informed care, we need to focus on well-being, we need to look at social determinant of health, that I think Beth is going to come back to tell us more about that, and there's a need to destigmatize the way that we language the risk factors and other elements on the pathway as well. So after the debriefing meeting, I sent a survey again to the panel to look at the degree of agreement. We achieve a content validity ratio of 1, indicating 100% agreement amongst the panel members. And we sent out a quadric survey to nurses who are working in the Indigenous communities across Canada. So far, we have 47 responses, with 80% of people endorsing the pathways. We got a lot of feedback from the respondents, and we're in the process of meeting up with the panel again to review individual items, some comments, and we'll get the finalized version, hopefully very, very soon. So it's still a kind of a work in progress, so keep that in mind. And I'll pass it on to Beth to explain a little bit more about what we have done so far.
Thank you, Kevin and Michelle. That was great. We're going to discuss now, like Kevin said, what changes we made to the document. So there was 3 documents in total. The first one that we adopted was the decision algorithm. We didn't change any of the main pieces to the ISTAP tool, any of the actual algorithm itself. We added pieces that we thought were culturally safe, and removed a few things that we felt were not as culturally safe. So the first thing, as you can see, we added the title. We changed the title to ISTAP Indigenous Skin Tear Decision Algorithm. The actual step-by-step is the same. We added the our NSWOC Indigenous Core Program logo. So the next box you can see is the holistic goals of treatment. We added the word holistic there, and we added points that were culturally safe and holistic. So for example, the first one is acknowledge and integrate the use of traditional knowledge in medicine, identify any barriers to care. And like I said, there's several there. I'm not going to read all of them to you, but yes, that box was changed quite a bit. And then the next piece was the treatment options. So we added with culturally safe care instead of with local wound conditions. So we made that change as well. And then the types of skin tears were not changed. The type 1, type 2, type 3 were not changed. The only thing that we did change was the photos. Those photos were validated as being Indigenous people. So we had to find photos that matched each of the types, and you can see that we added those into the tool as well. So that's the changes that we made for the first document. So the skin tear assessment pathway, as you can see in the title, we added for Indigenous people. And again, we added our core program logo. The next change we made, there's 3 in the original. We added a 4th. So in the general health, you can see that malnutrition was added. And then under physical functioning, we changed the wording to physical functioning instead of mobility. And we added injury. We changed the word from trauma to injury. So mechanical injury instead of trauma. And then under skin, you can see that we added the point saying poor skin integrity and skin hygiene. So washing and skin moisturization. And then the other new column that we added was the social determinants of health. So food security, health equity and equality, mental health, well-being and wellness. And again, I'm not going to read all of them to you, but that was one of the main changes that we made for that box. So as you can see, we didn't change the next box, the no risk factors and reassess with change of condition. The other box beside that with high risk, we actually did add concerns related to social determinants of health. And then in the final box, we added to see the ISTAP Indigenous skin tear decision algorithm. And for the last document, the third document, person with a skin tear, we changed it to say Indigenous person with a skin tear. And then instead of it saying in the first box, treat the cause, we changed that wording to identify the cause. And we also added polypharmacy and polysubstance use. Physical functioning, we added instead of ambulation. Change that. Under skin, we put previous skin tears, fragile skin, what was it here? And mechanical injury instead of mechanical trauma. And then we added a whole section on social determinants of health under that, identify the cause. The box beside that, local wound care, we added 1 point, acknowledge and integrate the use of traditional knowledge and medicine. We added careful dressing removal. And then it also, at the last point, was assess and classify according to the ISTAP Indigenous skin tear algorithm. So that was added as well. And the third box over, patient-centered concerns, we changed patient to person. And then we added quite a few points here. It had ADLs. We put enable activities of daily living, spelled it out. Pain control, address pain and other symptoms. Educate client and circle of care and caregivers. We said educate person and their circle of caregivers. And then we also added support the use of traditional practices and medicines, promote cultural safety and decolonize health system, foster relational care. And then going down under debridement, instead of saying avoid sutures and staples, we put do not use sutures, staples, or adhesive wound/skin closure strips. And then the final thing that we added was underneath infection and moisture balance, we added a block that says non-healing wound and non-advancing as we left, but we added a non-healing wound and then to reevaluate the skin tear. And as Kevin had mentioned, this is ongoing. We did get feedback with our survey, and we had some other suggestions. So we are still working on this. This is just the draft that we have now, and it's still in progress. So this is not the final version, but this is what we have to date. So integrating Indigenous cultural safety into the skin tear assessment, Michelle and Kevin spoke about this earlier, but I just wanted to reiterate that cultural safety is essential in wound care. How we approach the person matters as much as the assessment itself. So ask permission and explain the purpose. Always seek consent and clearly outline what you're doing and why. This builds trust and respect the personal boundaries. Use respectful person-centered language. So describe the skin tear without judgment or jargon. Keep the focus on the person and not on the wound. Honor preferences, values, and support people. Ask about cultural and personal needs before starting your assessment. Respect requests for support, persons, and modesty. Cultural safety is defined by the individual. We don't dictate the care that the care is culturally safe, the person does. Stay open, adaptable, and responsive to their experience. Integrating cultural safety strengthens trust and leads to a better outcome. Thank you.